Good evening. This is Dr. William Long from Charlotte, North Carolina, and MDVIP. Welcome to the Longevity Lounge. Tonight, I'm excited. I have a guest, Tim Montgomery, who's finishing up his pharmacy doctorates at Wingate University. He's a honored veteran of 15 years in the U.S. military and has suffered with severe back pain for over 15 years, has had multiple surgeries, and is really an expert on back pain. Good evening, Tim. Glad to have you here.
Thank you, Dr. Long. Thank you for the introduction. Glad to be here.
Yeah, so I was going to let you tell the audience why the heck did we choose this topic tonight?
This topic is very near and dear to me. I mean, for the last 15 years, I have suffered with chronic back pain, and that's mixed with bouts of acute, you know, periods where, I have damage that's occurring and worsening, if you will. So,
Yeah, I knew you had surgery several months ago. That was your third one, so you're certainly well acquainted with this problem. I was going to ask you, so why this topic? I mean, I know just on a personal level, I don't know anyone that doesn't have problems with their back at some level. Now, obviously not at the level you do, but what percentage of the country would you say really suffers with significant back issues?
well, depending on the statistic and the source, I mean, it's estimated 83% of all patients have chronic back pain at some
Right.
point in their life.
Mm-hmm.
That's a large percent of the population.
It is, and like I said, I think it'd be unusual unless you're maybe 15 or something. Everybody seems to have trouble with their back at some point, and it seems like a lot of times you get injured doing almost nothing. It seems almost out of proportion of what you're doing when you hurt yourself. So we do have a large population, probably just about everybody that's listening to us today. So what would you say? When does someone need to go in and have themselves evaluated?
Great question. And from a pharmacist's perspective and from a patient's perspective combined, when you can't manage it with over the counter remedies, if you will, and it lasts more than 3 weeks. So if
Yeah,
that pain persists longer than 3 weeks, you definitely have a problem. It's no longer just I did a little something and I'm sore. You need to go get checked out.
that's right. I think a lot of people probably self-medicate themselves, with advice from their pharmacist or family friends who've had the problem and using over-the-counter preparations. So like, what would make someone go to their physician? And we'll start with primary care because that's probably the usual entry point before you get to the orthopedics or the neurosurgeons. What kind of things do people need to be concerned? Like, if I'm having X, what do I need to go and get myself looked at?
Well, it based on the type of pain, how you would characterize the pain,
Right.
how the patient would describe it. So if they have pain that does not go away at all and seems to get worse with certain activities, that's an indicator. If they have pain that seems to be traveling or shooting down their legs,
Right.
radiating, if you will, that's another indicator. Or just sharp pain within like the center of your back, the spine that you would describe as like a hot stabbing pain. Those are good indicators.
Right. I know. Yeah. That's from my perspective. That's the thing I'm looking at too. People that have pain radiating into the legs. I think the things that worry me even a little more would be like an extremity weakness. Like if you're having, like an inability to get up and down stairs or get up and down out of the chair, that kind of thing. And you could probably speak to this better than me. It's sort of weird. Like musculoskeletal pain, like arthritis, is different than nerve pain. But wouldn't you like
Yeah,
describe those
absolutely.
differently?
Absolutely. I've felt a a couple of different types of nerve pain is what neurologists, the nerve doctors, if you will, have described it. With a numbing pain, it's
Hmm.
deep, it's dull, it's there, but the longer you kind of persist with activity, keep going, the worse it gets, but you finally lose feeling within that extremity, that leg, if you
Right.
will. That,
Yeah, I
that's
often think about, it's one thing. I'm old, right? I get some joint pains. That's kind of on a, 3, 4 level. But buddy, you bust a tooth or get a tooth pain or any kind of nerve pain, just is much, much worse. You just cannot get comfortable. I imagine even yourself, sleep problems, you have trouble keeping up with your, things you got to do during the day. How you can't even think straight. You're hurting so bad.
yeah, absolutely. Dealt with that quite a few times myself, and you don't really realize it that the pain is affecting you that way. But if all you can think about is, oh my God, I gotta, get home or sit down or lay down or get in the vehicle and turn on the heated seat just to start relieving this pain.
Yeah. Yeah, I think that's when you get to that point, that's when you need to get some professional help. So now you go to see your primary care doctor. Typically, what kind of studies, what kind of examinations could the audience expect? Like once they get there and they say, "Oh, you clearly have something worse than like a pulled muscle." What kind of studies do we see get done?
Three typical studies, depending on where you go. First, foremost, and because it's probably the cheapest for insurance to cover, is an X-ray. An X-ray will
Right.
tell you and your doctor a lot. It will let you know whether or not there's a broken bone or a vertebrae within the back. If there is like a disformity going on or something going wrong with the anatomy there, it can let you know, such as scoliosis or some abnormal curving of the spine. Also, disc degeneration. They
Right.
can look at an X-ray and determine between the bones whether or not that space is correct or if it's smaller. That's one
Right.
indication. Next would be an MRI, or excuse me, let me back up. A CT scan, a little quicker than an MRI. CT scan is going to show a little more, or excuse me, it shows a lot more than the X-ray, but not as much as an MRI. It's going to show
Right.
some of the other soft tissues, but not as much detail. And then last, finally, you have the MRI. It's going to show your doctor and or surgeon, if you have to go that far, in great detail what's going on.
Yeah, I agree. I think your X-rays. Unfortunately, the insurance companies like that because it's a relatively inexpensive study, and then depending CT or MRI is probably where we go next, and that's usually going to give us the anatomy issues that we're suffering with. So once you get these tests, what are the causes that occur most frequently that cause back trouble?
For middle-aged adults and older, usually osteoarthritis. It's just degeneration that comes with the region of the spine. You're wearing out those joints within the spine where the bones manipulate with each other, and it causes inflammation at those various points where they interact with each other, and it can just cause pain.
Right. Yeah, I think, when I get these reports back, like you said, you're going to see either disc injuries, arthritic changes, and you and I, are so familiar with the anatomy, but the bones are stacked on top of one another with a disc material between them. And, you can get injury to the disc itself, which comes out and pushes on the nerve. Then you might even explain like the terms foraminal stenosis. You'll hear this, spinal stenosis. Those are all forms of arthritis as well. Correct?
Yeah, so the spinal stenosis, as you were talking about, I've had that. described in some of my imaging, where the spinal cord actually goes through the large vertebrae.
Hmm.
There's a space within those bones that the spinal cord travels in through, down through, and the arthritic changes causes a narrowing.
Hmm.
That's what stenosis means, is a narrowing.
Correct.
So if it's central canal stenosis, that's the narrowing of the spinal cord itself, and then the foramen that you were talking about. That's where the nerves exit the spinal cord and go to the respective limbs and areas of our body. So that would just be a narrowing where those nerve roots exit.
Right. And I think, and that information frequently, at what level that stenosis or narrowing is occurring or disc is herniating, it's going to press a different nerve that goes into a different location in your leg. So we, as providers, can typically tell the person, like, oh, it looks like your L5 nerve root on the right's being pinched. It's kind of interesting, once you get the neuroanatomy down, you can pretty much pin down where the person's problem's typically coming from, even before you get the study, either the MRI, CT, as you were mentioning. Um, I think, I guess, just to stop for a moment, maybe let's go back and let you reiterate what are the symptoms that would make you go see your physician? Because I think that's an important point, because I think a lot of people will nurse these things, with the medicines they have at home. But when does that person need to, like, nope, you need to go see somebody. This isn't going to go away.
Like like you touched on earlier, like a weakness. So besides the few that I shared earlier, in addition to that, like if you have a weakness, if you're trying to get up and down, maybe just say out of your car, and it feels like your leg is super weak and it's going to give out. That's a good indicator, especially if you
Hmm.
have that weakness along with the back pain. If you were trying to climb stairs, and it feels like you can't support your full weight as you used to on either leg going up and down the stairs, another
Right.
good indicator.
Yeah, I agree. I think any kind of neurologic, quote, neurologic change, which is weakness, numbness, of course, that classic burning down the leg. You hear people all the time say, "Oh, it's my sciatica. It's my sciatica." Yeah, but yeah, I agree. And I just think people need to be aware that when you get to a point where you're developing some kind of weakness in an extremity or non-relenting, burning neuropathic pain in an extremity, it's time for you to go see someone. With you having a really great background in pharmacy, I was going to spend some time on management, because I think, everybody's fearful. Oh, you have to have surgery. You have to have surgery. Well, that's not necessarily the case. So maybe just take us through, like, the escalating, things we do in terms of treatment for people that we know have some anatomy back problem, like a sciatica, herniated disc, foraminal stenosis. What things are available to people?
Sure. First and foremost, and this is like, okay, if you have the chronic pain, but maybe you would characterize your pain maybe at like a 4 or a 5 out of 10.
Hmm.
It's there, it's persistent, it's not going away, it's aggravating, but you still can get through life. It just slows you down. One of the number one causes or contributing factors to osteoarthritis, the one I just talked about,
Hmm.
would be overweight, or people that work in labor intensive industries such
Yeah.
as bricklayers.
Yeah, a lot of
So,
wear and tear on their back. Yeah.
right, you got a lot of wear and tear on the back. If you can lose weight, lose weight. A weight,
Hmm.
a reduction in weight is going to help relieve the
Yes.
strain on the back and on those discs, and some of the problems that come with that. So lifestyle modifications. Next would be just mild and moderate exercise. Don't go crazy. Don't go kill yourself working out,
Right.
but just moderate exercise. Maybe aim for 150 minutes a week, what guidelines recommend.
Hmm.
Just moderate intensity, even if you spread it out over 5 days or 3 days, depending on how you do it. But The idea behind that is to build strength, your
Hmm.
core strength, skeletal muscle, which helps support our skeleton and those joints. They work together in combination. So we strengthen the muscles that help support everything. The other is to introduce movement back into joints that we probably don't use that much.
Right.
So if we do one particular type of work and it doesn't involve a lot of twisting or turning or movement, some of the joints that are not used very often like to seize up a bit. And
Right.
if they're
Right.
arthritic, then there might be some pain that the patient is going to experience when they start to use those joints just a little bit.
Hmm.
But pushing through that just a little bit with exercise, along with weight loss, a healthy lifestyle, that's one way to help improve it. Next would be dietary. If you eat a healthy diet, well
Hmm.
balanced diet, you don't have to necessarily go crazy in one direction or another, but just avoid the simple sugars and high carbohydrates that
For the
feed
inflammation.
inflammation.
Yeah. Yeah.
Exactly.
Now, how about things like, and I know we do this as physical therapy, occupational therapy. You and I recently had a conversation with some local physical therapists. There's a lot of things other than just like we were talking about dry needling. Could you go into some of those modalities that are being used as well?
Sure, and I would kind of classify that as clinician assisted. Would be kind of like the next step up. So
Yeah.
yeah, physical
Okay.
therapy would be almost first and foremost if this is the first time you've ever been diagnosed
Hmm.
with the chronic pain. Your provider might ask you, "Have you been to physical therapy?" If you say no, that'd be the first good place to go is physical therapy, and it's just a clinician assisting with what I just told you. So
Sure.
we introduce movement to those joints that you don't use that much, help rebuild strength to help support that. And they also have modalities like that's just other treatments, if you will, non drug related treatments, such as heat packs. They can put heat packs on
Hmm.
those areas of your body that are affected, the low back. Or then there's also like acupuncture, dry
Right.
needling,
Hmm.
one, and also TENS units, where it's
Yes, I think
a
that's
little bit of
commonly used.
electrical stimulation through the muscle groups that surround those problem areas of your back.
Right. Yeah, I think that tends to be the thing that I see as well. You go and there's some of these newer things like the dry needling has been pretty well accepted, acupuncture as well, and then 10 units huge. Now, I guess once you've sort of been down that road, again, pharmacologically, now you and I talk. I mean, there's clearly the arthritic drugs are relatively safe, with the exception of maybe some gastrointestinal side effects and whatnot, maybe kidney if you have diabetes. But once you get past the basic anti-inflammatories, now you're talking medications that are typically controlled, typically a lot more dangerous to use. What's your feeling on that as a pharmacist and as someone who's literally suffered with this for years?
Outside, well, three basic categories of your drugs to treat the pain aspect. If it's nociceptive pain, that's pain that occurs, you experience due to damage.
Right.
Dr. Long already said, okay, outside of your non-steroid anti-inflammatories, there are steroidal drugs. They can be used short term. That can help reduce inflammation if you have a massive flare up.
Mm-hmm.
Seen that used. But there's also like, I want to start on the outside of the body, topical. So
Mm-hmm.
if there are creams or gels like diclofenac gel, also known as
Right. One of the
Voltaren,
arthritic drugs. Right.
that can be applied to a certain area, a localized area, if you're just having kind of concentrated pain in one area. Also, lidocaine patches,
Mm-hmm.
prescribed quite a bit. We can argue one way or another whether patients really feel like they get a benefit. They're supposed to be
Yeah.
on for a certain amount of time, then they take off. It's like 12 hours on, 12 hours off, and it can become cumbersome or kind of a burden to deal with, maybe greasing yourself with an ointment or a gel, or playing with a patch and the stickiness.
Yeah.
So patients like even myself, I'd rather take a pill than have to do all this other stuff, right?
Yeah, I think most people, that's right.
So in order to make sure the medication is right, the pharmacist wants to make sure the medication that's being prescribed is prescribed appropriately for the right reason.
Right.
It's not that we're trying to challenge your doctor, but there's a lot of medications that a patient might be placed on, and you might see two or three, four different providers once you develop an issue like this, and your pharmacist is your next best friend.
Yeah,
Make
I agree.
sure
I
if
think
you
that's
see,
a lot of polypharmacy there. A lot of people are seeing either orthopedic surgery, neurosurgery, their primary care doctor, and if having problems, they end up in the ER, get another prescription. So I agree with you, Tim. I think that's, the pharmacist's role becomes very critical there because you have a lot of different people, and for people that are miserable. I mean, I understand why they're doing it. They're in horrible pain. I know. You mentioned a second ago about the steroids. I mean, I know that the pain management guys and some of the orthopedic and neurosurgery guys will inject steroids into your spine. That's another mode that gets used frequently before surgery. I think surgery would be the last option for people. How do you feel, or what's your feeling on using opioids for chronic pain? I mean, I know we try to be very judicious with this and be really cautious with this, but there are some people in which this is an appropriate route to go.
right, I'm glad you asked that. There's a couple of things that support my answer in this. But first and foremost, when and where appropriate. If the patient is reporting moderate to severe pain, the DEA, FDA even agree that yes, that's when they're indicated.
Hmm.
In the with a proper diagnosis after a proper escalation of, okay, did we try other agents? Did they fail? Okay, we finally end up at opioids. Yes, but there's still guidelines to go along with it. Just don't
Hmm.
throw a whole bunch of opioids at a patient. Maybe
No,
we've heard before
exactly.
horror stories. Oh, they got seen, they had a little boo boo, and then now they're just stuck on opioids for the rest of their life. No,
Yeah. Yeah,
there's
sadly, and you and I know this, is it seems like with the back pain realm, my post-operative failed surgeries are the people that really do have a need for these products and have to be monitored and whatnot. There's some agents we talked about, that are not really as dangerous to use, buprenorphine being one of those.
yeah,
But I think there's a large arsenal of these medications, and if used in the right way, can really help people manage their lives so they're just not incapacitated with pain.
absolutely. And to add on to that, the the patient and the prescriber work closely together in this, as it's not just here you go, here's the medication. It's based on functionality. Um, those opioids are being prescribed. They're not going to take away the patient's pain completely. They might get the patient if they're saying, "Hey, Dr. Long, I'm at a 7. Okay, here I'm prescribing this. It's gonna help take you from a 7 down to a 3 or a 4."
And I think that's a good point. I think some people think they're going to be absolutely pain free, and I think that's probably not a realistic goal for most people. I think what you mentioned, to me, what I'm usually shooting for is to give people their lives back, function, let them enjoy things they used to enjoy, and be in pain that's manageable. So they can get their life back. 'Cause a lot of these people become very incapacitated with their pain. So Tim, if we were going to just kind of do the takeaways, what are the things you and I can kind of talk? What do we want the audience to take from this little conversation we had?
I got these already kind of prepared. If you give me a second, I'll pull them up. I had 7 key takeaways that I really wanted to share. 8, excuse me. One of we already went over was that we're not really going to fully achieve a state of being pain free.
Correct.
Second, it pain management of chronic low back pain is very challenging. It has multiple factors that influence that the effectiveness of the therapy, and it you're not going to get to that optimal state. Ideally, you're not going to get there real quick. It's going to take some work. Next, the goal was to regain the most function at the lowest possible dose of medications.
Yep. Probably number one for me.
The next is, it goes closely with that, is don't overdo it when you are feeling good.
Right. We see that. You're right.
So if you're feeling great and you feel like you can go conquer the world, you're not feeling your pain, maybe you're having a great day, and you feel like you want to go cut the grass and build a new doghouse or whatever, be very careful. Do a little bit of something, but don't overdo it. If you wouldn't be able to do all that without the medication, it's a good indicator that if you do it while on the medication, you're going to pay for it once the pain meds wear off.
Yeah, exactly.
Again, achieve a healthy body weight, even if possible while during the treatment process. This is again going to reduce those things that we already talked about, like the additional strain on other areas that contribute to that overall back pain.
Right.
Keep an open mind to other agents when being treated, not just opioids, but we call them adjunctives, or just add-ons, if you will, that help achieve that optimal therapy state.
We didn't go into that very much, but you and I have explored quite a bit of those, the drugs like ketamine and Lyrica and gabapentin. I mean, we could spend probably a whole talk on medical treatment of this, but yeah, I think that's a really good point, that if your physician or surgeon or orthopedic surgeon, if they are recommending something be added to your pain medication, don't just blow that off, because they really are quite effective.
Right. The next, we've already talked around a few times. It's working closely with, maybe your pain management doctor, or if that's your primary care provider, whoever that doctor is that's helping manage your pain. You got to communicate very clearly and frequently with them. If your situation changes, don't sit at home miserable and be a prisoner of your pain.
Right.
Or if your situation improves, let them know, and so that you can start de-escalating some therapy if you are on some higher power drugs, because you're not necessarily going to need them.
As well, so
you don't want it to contribute to the potential of becoming addicted to it.
Mm-hmm.
And last, not least, but what I wanted to share with fellow veterans, if you are listening to this, especially those who are still in the service, don't hold off on going in and getting seen. That's one of the mistakes that I made. I held off going to sick call, is what we call it. I thought I was going to be tough, push through the pain, but I had a serious problem.
Yeah, it gets back to our original thing. Don't ignore it. There's certain things when you start having them, you need to get looked at, so you're not making the situation worse. I think that's great advice, Tim, and I really appreciate you getting on here and sharing, sadly, your personal experience with this. And I'm hoping if we can help one person, it's worth doing this today. And Appreciate it, buddy. And I'm excited you're almost through pharmacy school. We'll be glad to have you out here working alongside us.
Thank you very much, Dr. Long.
All right. So before we end, I just wanted to say that these talks are not supposed to be a substitute for your primary care, your physician-patient relationship. We don't intend for that to be the case here. This is just advice, and you need to discuss any of your problems with your own personal physician. Thank you from the Longevity Lounge.